Good morning. For teaching rounds today, I put together a clinical case explainer. We're going to demystify colorectal cancer screening by treating it as exactly what it is in practice, a real-world medical investigation of pure prevention, not just early detection. I'll be presenting this case to you today as if we were walking from a routine clinic encounter all the way down into the molecular pathology and finally, defending the precise clinical decisions we have to make for this patient.
Here's a quick look at our roadmap. Act 1, the asymptomatic patient. Act 2, the biological deep dive. Act 3, guidelines and testing. And Act 4, the final pathology report.
Act 1, the asymptomatic patient. We're starting with our patient, a 58-year-old man presenting for his first ever colonoscopy. Now, this is a routine clinic visit, not an admission. When you talk to him, he feels completely well, right? No abdominal pain, no nausea, no vomiting. Formed daily stools, no melena, no hematochezia, and absolutely no change in his baseline bowel habits. His weight has been totally stable for years, and his review of systems is completely negative. The physical exam, just as reassuring. Soft, non-tender abdomen, no palpable masses, no hepatomegaly, and a totally normal rectal exam. His hemoglobin is a robust 14.1, and his iron studies are perfectly normal. But clinically, we know that a reassuring exam in this context is completely unhelpful for risk stratification. Early colon cancer, and especially premalignant adenomas, are biologically designed to be silent. Right-sided colon lesions grow in this highly capacious area where stool is still liquid, meaning they just don't cause obstructive pain. Any occult bleeding is slow, intermittent, and degraded by bacteria long before it reaches the rectum, so it won't present as overt hematochezia, and it won't drop his hemoglobin until the lesion is quite advanced. So all that reassuring history, it doesn't lower his true risk by even a single percentage point.
Despite the normal blood work, let's tally up his actual risk ledger out loud, focusing on the history that really matters. First, family history. His father had colon cancer diagnosed at age 62. Then his heavily modifiable risks. He's an ex-smoker with a 20-pack-year history. He's got a BMI of 32 with central adiposity, 6 alcoholic drinks a week, type 2 diabetes for the last 4 years, and a diet heavily skewed toward high red meat and low fiber. Let's look at the biology of why those matter. Central adiposity and type 2 diabetes create this state of chronic insulin resistance, right? That lowers insulin-like growth factor binding proteins, leading to high levels of free IGF-1, which binds directly to the colonic epithelium and aggressively promotes mucosal proliferation while inhibiting apoptosis. Meanwhile, that high red meat diet increases his exposure to carcinogenic and nitroso compounds. And the low fiber slows his bowel transit time, basically maximizing the duration those carcinogens sit right against the mucosa. So that's 8 massive risk factors driving cellular turnover. Protective factors, like daily aspirin or high physical activity? 0. He has absolutely none.
Which brings us to the family history rule. Because his dad was diagnosed at 62, the standard rule dictates he starts screening at age 40, or 10 years before the youngest affected relative, whichever comes first. Well, 10 years before 62 is 52, but the rule mandates the earliest date, so that's age 40. This rule exists to catch the adenoma entirely before the carcinoma phase. So his target was 40. He's 58. That means he isn't just a little late. He is 18 years overdue, making this a remarkably high-stakes scope.
Moving to Act 2, 2 roads to cancer. To really get why this asymptomatic guy desperately needs to be scoped, we have to look closely at the cellular biology. Because a polyp is merely a description of tissue protruding into the lumen, it is not a diagnosis. To get the diagnosis, we have to look at the genetics.
This brings us to the classic two-hit hypothesis. Colorectal cancer needs a stepwise accumulation of somatic mutations. We divide these into 2 buckets. Oncogenes are a gain of function. Think of it like the accelerator in a car getting jammed all the way down. Proliferation signals are permanently on. Tumor suppressors are a loss of function. The brake line is cut. The cell literally loses its ability to halt the cell cycle or trigger apoptosis. To become invasive cancer, a normal epithelial cell absolutely needs both, a jammed accelerator and a cut brake line.
Let's walk through the conventional adenoma-carcinoma sequence, which drives the vast majority of these cancers. Tumor initiation starts with the loss of the APC gene on chromosome 5q, the ultimate gatekeeper of the colon. When both copies are lost, Kripp cells ignore stop signals, beta-catenin isn't degraded, and the epithelium hyperproliferates into a benign adenoma. Then progression. We get a gain of function in the K-ras oncogene, there's our jammed accelerator. Next, we lose the DCC tumor suppressor gene on chromosome 18. Finally, the late loss of p53, the guardian of the genome. That final p53 loss is what's tied directly to malignant invasion. The vital thing to note here is the tempo. This whole predictable genetic sequence takes roughly 10 silent years. That silent decade is the exact fully interruptible window that our screening colonoscopies exploit.
But there's a stealthier, separate road called the serrated pathway, and it never touches the APC gatekeeper gene at all. Contrast this aggressively with the conventional sequence. Instead of APC, this lane relies on an early BRF mutation to form a sessile serrated lesion. From there, through an epigenetic process called CpG island methylation, it heavily methylates and completely silences the MLH1 gene. Note that MLH1 is not mutated here, it is silenced. This creates a profound mismatch repair defect and a microsatellite unstable carcinoma. Different genes, different tempo. And practically for the endoscopist, the serrated lane produces flat, pale, right-sided lesions that are often the exact same color as the surrounding mucosa. They are incredibly easy to miss, and because of that, they are a primary driver of interval colon cancers, the ones that pop up tragically between scheduled screenings.
We also have to bridge this biology over to the high-risk inherited germline syndromes, where patients are born with the first genetic hit already in every cell. Familial adenomatous polyposis, or FAP, is a germline APC mutation. These kids develop hundreds, even thousands of adenomas starting in early adolescence. Lifetime cancer risk approaches 100%. Then you have Lynch syndrome, a germline mismatch repair defect involving genes like MLH1 and MSH2. They only develop a few polyps, but because their mismatch repair is broken from birth, those polyps progress incredibly fast, typically on the right side with a very young onset. These syndromes dictate totally separate, highly aggressive schedules. For FAP, we start scoping at age 10 to 12. For Lynch, 20 to 25.
Act 3. Sorting polyps and tests. Let's apply this foundational biology straight into our clinical guidelines.
Every single polyp we pull out goes into one of two buckets: non-neoplastic or neoplastic. The non-neoplastic bucket includes things like small distal hyperplastic polyps in the rectum, which carry basically zero cancer risk. We do have to remember the Peutz-Jeghers hamartoma exception here, which crosses the wall and can transform, but otherwise our main focus is the neoplastic bucket. We grade adenomas purely by their microscopic architecture. Tubular adenomas have rounded branching glands, lower risk. Tubulovillous have mixed architecture, intermediate risk. Villous adenomas feature these long frond-like villi and have a very high malignant potential. And remember, every single adenoma contains dysplasia by definition. They are inherently precancerous. The only question for pathology is whether that dysplasia is low-grade or high-grade.
Which brings us to a definition you absolutely must commit to memory, because it's the linchpin of post-polypectomy surveillance. An advanced adenoma is any lesion meeting any one of these three criteria: 10 millimeters or larger, presence of any villous component, or high-grade dysplasia. Just one of those is enough. Finding an advanced adenoma permanently alters the patient's risk profile and puts them on a much tighter surveillance leash. Small hyperplastic polyps change nothing. Advanced adenomas or sessile serrated lesions change everything.
So how do we find them? For average-risk patients, the start age recently dropped to 45 due to rising incidence in younger cohorts. We've got a whole menu. The gold standard, colonoscopy every 10 years. Flexible sigmoidoscopy every 5. CT colonography every 5. Stool-based FOBT or FIT yearly, or fecal DNA every 3 years. Blood-based DNA is advancing, but isn't primary guideline standard yet. We just have to remember the limitations. A flex sig only reaches the splenic flexure, meaning it completely misses the right colon, which, as we discussed, is exactly where those stealthy, BRAF-driven sessile serrated lesions live.
And here is an absolute cardinal rule for the clinic regarding these alternatives. If a patient has any positive non-colonoscopy test, a positive FIT, fecal DNA, or CT, that immediately mandates a full diagnostic colonoscopy. You must never, under any circumstances, order a repeat stool test to try and confirm or dismiss it. A positive alternative test earns a scope. End of discussion.
But if we're banking on the 10-year colonoscopy as our gold standard, it actually has to be high quality. A poorly prepped or rushed scope is not a 10-year scope. The endoscopist needs a proven high adenoma detection rate, because a higher ADR means fewer interval cancers. Cecal intubation has to be documented with photos of the appendiceal orifice and ileocecal valve. Withdrawal time must be at least 6 minutes to allow for meticulous mucosal inspection, and the prep must be adequate. If it's poor, you don't clear them for 10 years, you bring them back. Also, keep in mind, patients with inflammatory bowel disease like ulcerative colitis get totally separate schedules, typically starting at 8 years post-diagnosis because of the chronic inflammation driving dysplasia.
Act 4. The pathology report and the plan. Let's take all this cellular biology and guideline logic, bring it back to our 58-year-old patient, and finalize his plan.
So, his report is back. Procedural metrics were stellar, excellent prep, cecum reached, everything removed en bloc. But the findings were extensive. He had a 12mm tubulovillous adenoma in the sigmoid, a stealthy 8mm flat sessile serrated lesion hiding in the ascending colon, 2 tubular adenomas under 10mm in the descending colon, and 3 small hyperplastic polyps in the rectum.
We have multiple lesions from across the entire colon spanning both the non-neoplastic and neoplastic buckets and hitting both the conventional APC pathway and the serrated pathway. The clinical question is, which specific single finding actually dictates how soon he needs to be scoped again?
3 years. He is placed on a strict 3-year leash. This interval is driven entirely by the 12mm tubulovillous adenoma in his sigmoid. That single lesion hits 2 different criteria for an advanced adenoma. It's over 10mm and it contains villous architecture. Because of that advanced adenoma, his 10-year window is gone.
We have to explain to the patient why the other lesions didn't actually lengthen or shorten this 3-year interval. The hyperplastic polyps have no malignant potential, and the serrated lesion and small tubular adenomas independently wouldn't demand a 3-year return. We also need to contrast this with the intervals he didn't get. If he only had 1 to 2 small tubular adenomas, he'd get 7 to 10 years. An explosion of more than 10 adenomas? 1 year. If that 12mm lesion was over 20mm and required piecemeal removal, he'd be back in exactly 6 months to ensure nothing was left behind. This perfectly reinforces the pearl. Never accept a report that just says, polyp removed, without knowing the histology. The histology is the diagnosis.
Ultimately, our plan isn't just about scheduling that next scope in 3 years. We're treating the whole patient, which means aggressively counseling him on that modifiable risk ledger. We need to push weight loss, physical activity, high dietary fiber, and a sharp decrease in red meat and alcohol to lower mucosal carcinogen exposure. We also need strict type 2 diabetes control to drop those circulating IGF-1 levels. And one last clinical pearl for rounds, our patient's iron studies were normal, but if you ever see unexplained iron deficiency anemia in an adult, the colon gets scoped. Every single time. It is colon cancer until proven otherwise.
Because finding and removing these pre-malignant polyps totally interrupts the disease sequence, we aren't just looking for early cancer. We are actively practicing pure prevention. Which leaves us with this final thought on rounds today. If the adenoma-carcinoma sequence gives us a full, silent, 10-year window to literally stop cancer before it starts, how many of those sequences are silently ticking away in our asymptomatic patients sitting out in the waiting room right now? It is our job to go find them. Thanks, everyone.